Hey everyone, and welcome to the Deep Dive. We're going microscopic today, folks, diving deep into severe community-acquired pneumonia.
Severe CA.
That's the one. We're going to be looking at the WHO Guidelines, Chapter 27.
Oh, excellent.
Which, as a fellow medical microbiologist, this is like our Bible for all things pneumonia. We'll also be pulling in some insights from the WHO's AWARE book on antibiotics.
Great.
Which I always find super helpful for making sure we're using the right antibiotic at the right time. We're talking about those access, watch, and reserve categories.
Absolutely, a key tool.
So get ready to uncover some fascinating twists and turns, because even seasoned microbiologists like us might find some surprises in these guidelines. And to guide us through this intricate world of severe CAP, we've got our expert here ready to shed light on the details and connect the dots. Ready to get started?
Absolutely. Let's dive in. Severe CAP can be tricky to manage, so understanding the nuances is key.
For sure. I've always found the distinction between regular CAP and severe CAP, well, a little fuzzy. Is it just about how sick the patient looks, or is there a more concrete definition we should be using?
You've hit on a crucial point. The WHO guidelines are very specific about what makes CCAP severe.
Okay.
It's not just feeling awful, it's the level of risk. Severe CCAP means the patient has a higher short-term risk of dying.
Right.
And it often requires hospitalization, sometimes even intensive care.
Okay, so that increased risk of mortality really sets it apart.
Exactly.
Makes sense. Now let's talk about what we see in the clinic, the clinical presentation. We've got those usual suspects, right? Cough, difficulty breathing, fever.
Yes.
But the guidelines also mention these extrapulmonary features, which can be tough to catch, especially in older patients. Can you break that down for us?
Extrapulmonary basically means outside the lungs.
Go ahead.
So we're talking about symptoms that go beyond the typical respiratory signs. Things like confusion, disorientation, even altered mental status.
Wow. So it can really affect the brain.
It can. And another curveball, fever might not always be present, which can throw us off.
Mm-hmm. So it's like pneumonia's playing hide and seek with us.
Exactly.
Got to be on our toes. So we can't just rely on those classic symptoms, especially with older patients.
You got it. We have to look for clues outside the respiratory system.
Just like being a medical detective.
Precisely. Early recognition of these subtle signs is crucial because it can mean the difference between timely intervention and, well, a worse outcome for the patient.
Absolutely. All right, let's move on to the lab workup. The WHO guidelines really stress the importance of lab tests in severe CAP. It's like they're saying, don't even think about treating without them.
And they're right. Lab tests are key in these cases.
Okay.
They help us figure out how severe it is, if it's bacterial or viral, and ultimately what treatment to go with.
So let's break down those tests. The guidelines list a bunch. Blood cultures, sputum tests, urinary antigens.
It's a lot, yeah.
Can you walk us through the key ones and why they're so important?
Imagine a patient comes in with suspected severe CAP. We start with blood cultures. This tells us if the bacteria are in the bloodstream, which can be more serious.
Right.
Then a sputum sample to pinpoint the bacteria in the lungs. Helps us choose the right antibiotic.
Okay.
And for those sneaky pathogens like Legionella and Streptococcus pneumonia, urinary antigen tests are our go-to.
So we're casting a wide net using different tests to catch those different pathogens.
Yes, exactly. And each test has its strengths and limitations.
Of course.
It's about using them strategically, interpreting the results with the whole picture of the patient in mind.
Right. Speaking of specific tests, the WHO guidelines have a whole section on microbiology tests in severe CA.
They do.
They even have a table outlining the recommendations. Why are these particular tests, blood cultures, sputum microscopy, even tests for TB, considered so essential?
Well, it comes down to those most likely culprits in severe CA and the need for targeted treatment. We talked about blood cultures, but let's look at sputum microscopy. It helps us actually see and identify the bacteria causing the pneumonia, which guides our antibiotic choice, and TB. Well, it can mimic pneumonia, especially in high-risk patients. Ruling it out or in is vital for treatment.
So it's like detective work, using these microbiology tests to track down the culprit and plan our attack.
Exactly. Connecting the dots and making informed decisions based on the evidence.
Love it. Now, I noticed the guidelines also mention a bunch of other lab tests for severe CAP.
Oh yeah, there are a few more.
Beyond microbiology, what other values should we be looking at and why?
Think of these tests as giving us a big picture of the patient's overall health.
Okay.
Like blood urea nitrogen for kidney function, white blood cell count for immune response, and blood pH and gases to see how the lungs are doing. C-reactive protein and procalcitonin can help us gauge the level of inflammation.
It's like having a dashboard with all these gauges, each giving us vital information about the patient.
It is, isn't it?
And you, the expert, are able to read those gauges and make those critical adjustments to the treatment plan.
I try my best.
Speaking of getting a clear picture, the WHO is very clear. A chest x-ray is essential in suspected severe CAP.
Absolutely.
Why is imaging so crucial here?
Imaging is like looking into the lungs, confirming the pneumonia. We look for those infiltrates, which are signs of inflammation. And it helps us spot complications like pleural effusions or abscesses. Early detection can really make a difference.
It's amazing what a chest x-ray can reveal. But the source also mentions that chest x-rays can't always pinpoint the exact cause.
Right, it has limitations.
So it's not foolproof.
No, it's not a magic bullet. It can show us pneumonia is present, its severity and complications, but not always the specific bug causing the infection. That's where those microbiology tests shine. They're the key to identifying the culprit.
So we need both. Imaging to confirm and look for trouble, and lab tests to pinpoint the microbial mastermind.
Exactly.
Okay, now let's get to the heart of it. How do we effectively treat severe CAP?
Well, there are two main things. Hit those pathogens hard and fast with antibiotics and support the body's own defenses.
Give it that TLC to recover. What does that supportive care involve?
Think of it as providing the body with the resources to fight back. Oxygen therapy to help breathing, IV fluids for dehydration, medications to control fever and pain, creating the optimal environment for healing.
Okay, now I've always found the CURB65 score a bit tricky to remember. Can you break it down for us and how it guides treatment decisions?
Imagine the CURB65 score as our triage tool.
Okay.
It helps us decide where the patient should be managed. It looks at 5 things: confusion, urea, blood urea nitrogen, respiratory rate, blood pressure, and age 65 or older.
I see the acronym.
Each gets a point, and the higher the score, the higher the risk, the more likely they need to be hospitalized, like a risk calculator guiding the intensity of treatment. The WHO guidelines even have a table showing how the score relates to treatment decisions.
So it's not just about how sick they feel, but quantifying the risk. Okay, let's dive into antibiotic treatment. The WHO guidelines are very specific, even with dosages and durations.
Yes, they are very detailed.
It can feel overwhelming, but let's break it down. What are the first-line choices for adults with severe CAP, and why those antibiotics?
For adults, ceftriaxone or cefotaxime are our go-to options.
Okay.
They're broad spectrum, meaning they're effective against a wide range of bacteria, including Streptococcus pneumonia, a common culprit in CPA.
Makes sense. And what about those atypical bacteria? Do these cover those as well?
That's where clarithromycin comes in, especially if the CURB65 score is 2 or higher. It targets those atypical bacteria like Mycoplasma pneumonia and Chlamydia pneumonia. So combining it with ceftriaxone or cefotaxime gives us a wider safety net.
Like a double-barrel shotgun, ready for whatever bug we encounter.
Exactly.
Now, the guidelines mention specific dosages and durations for these antibiotics. Can you give us a rundown?
Sure. For ceftriaxone, it's 2 grams once a day intravenously or 1 gram once a day intramuscularly for adults. Cefotaxime is 2 grams every 8 hours, either IV or IM. And if we're adding clarithromycin, it's 500 milligrams every 12 hours, either orally or IV. The usual treatment is 5 days, but the guidelines stress flexibility, extending treatment if needed.
So it's not a rigid formula. We adapt to the patient's response.
Right.
Now, what if, for some reason, ceftriaxone or cefotaxime aren't options? What are our alternatives?
The WHO guidelines recommend amoxicillin clavulinate as a backup.
Okay.
The dose is 1 gram of amoxicillin plus 200 milligrams of clavulinate every 8 hours intravenously. And again, you might consider adding clarithromycin for those atypical bacteria.
Got it. So we've got our first-line choices and our backup, all with specific dosage and duration guidelines. Now let's switch gears for a moment and talk about the underlying mechanisms.
How it happens.
Yes. I know you love this stuff. Can you walk us through how cestropy actually develops? The source explains the pathophysiological process. I'd love to hear your take on it.
Picture this. You breathe in, and along with the oxygen come tiny microbial invaders.
Oh.
They start in the upper airways, but eventually reach the alveoli, the air sacs in your lungs, where gas exchange takes place.
And that's where things get messy, right?
Exactly. The alveoli become a battleground, the pathogens multiply, and your body fights back, releasing inflammatory stuff and sending white blood cells.
It's a war zone.
It is.
Yeah.
This response is meant to contain the infection, but sometimes it goes overboard, and the alveoli get flooded with fluid, making it hard to breathe. That's when those classic symptoms kick in. The cough, difficulty breathing, and fever.
It's amazing how this microscopic battle leads to those real and sometimes debilitating symptoms.
It is.
So let's zoom out a bit and look at the bigger picture. How common is CAP and who is most vulnerable?
CAP is a global issue.
Oh, yeah.
The WHO estimates that in 2017 alone, there were about 471 million new cases of lower respiratory tract infections, which includes CAP.
Wow, that's a huge number.
Yes, but it's important to note that many of those were likely viral bronchitis, so we should interpret those numbers with caution. But even so, CAP has a real impact, especially in low-income countries.
Right. The guidelines mention that the incidence varies with age and a country's income level. Can you elaborate?
In low-income countries, the incidence of CAP and the risk of dying usually increase with age, peaking in those 65 and older.
Okay.
Sadly, lower respiratory tract infections were the leading cause of death in 2016 there, with about 75 deaths per 100,000 people each year. And the highest incidence is actually in children under 5.
That's heartbreaking. It really highlights the need for prevention, like vaccination and improving living conditions.
It does.
What about in high-income countries? How does it look there?
The picture's a bit different. Lower respiratory tract infections aren't a leading cause of death overall.
Okay.
But CAP is still common in those 65 and older, and the risk of dying still increases with age.
So age is a consistent risk factor, young and old.
It seems so.
Now let's dive into the microbial world of CAP. The source gives us a fascinating breakdown of the usual suspects, and it's not always who you might think.
You're telling me it changes depending on the age group. In newborns and kids up to 2 months old, the main culprits are bacteria, specifically Streptococcus pneumonia, group B Streptococcus, and Enterobacterales or Staphylococcus aureus.
So it's the bacterial battleground in those early months.
It is.
What happens as they get a little older?
Between 2 months and 5 years old, viruses become more common,
Okay.
particularly respiratory syncytial virus, influenza, and parainfluenza virus. But Streptococcus pneumonia is still a threat.
Still lurking.
Yes,
And as those kids head toward school age, do the microbial players change again?
absolutely. Streptococcus pneumonia is still common, but we also see more of those atypical bacteria like Mycoplasma pneumonia and Chlamydia pneumonia. And those atypical bacteria, they're intrinsically resistant to beta-lactam antibiotics.
So they have a built-in shield against our go-to weapons.
Exactly. So we can't just use a beta-lactam for every pneumonia case.
We have to consider those atypical bacteria and adjust our approach.
Precisely. The right antibiotic for the right bug.
Right. And are there any other bacteria we see in children with CUM-EP?
Yes, we also see Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus. It's quite a diverse lineup.
And what about adults? Does the microbial landscape shift again as we get older?
In adults, viruses are still significant, either directly causing pneumonia or setting the stage for bacterial superinfection.
Okay.
But when it comes to bacteria, Streptococcus pneumonia takes the lead,
The usual suspect.
followed by those atypical bacteria, Mycoplasma pneumonia, Chlamydia pneumonia, and Legionella pneumophila, and of course, Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus are still potential players.
It's fascinating how the most likely pathogens vary so much with age.
It is, isn't it?
It's like a microbial mystery with clues that change depending on who's at the scene. But here's something that surprised me. The source says that in most cases, we never actually identify the specific pathogen causing bacterial pneumonia, even with all our fancy tests.
It's true. Sometimes the microbial world keeps its secrets.
Why is that? Why is it so hard to pinpoint the culprit?
Several factors play a role. Firstly, the causes of pneumonia can differ geographically. For example, Burkholderia pseudomallei is more common in Southeast Asia and Australia, while Coxiella burnettii is more prevalent in areas with livestock. So local epidemiology matters.
So it's not just the bug, but where it's hanging out.
Right. Also, the type of sample we collect influences our chances of finding the culprit.
Makes sense.
And the limitations of the tests themselves.
Yeah.
Varying sensitivity and specificity, like solving a puzzle with missing pieces and blurry edges.
I see.
Plus, just because we find a pathogen in the upper respiratory tract doesn't mean it's causing the pneumonia.
Oh, why is that?
The nasopharynx, the back of our nose and throat, is home to many bacteria, even when they're not causing trouble. So finding one there doesn't automatically mean it's causing the lung infection. We have to consider the context and all the evidence.
So context is key. Okay,
Yeah.
let's solidify our understanding with a little test your knowledge segment.
Sounds fun.
Ready to put that microbial expertise to the test?
Bring it on.
Okay, first question. What's the most common bacterial cause of community-acquired pneumonia in all age groups after the first week of life?
That would be Streptococcus pneumonia. It's everywhere, especially in CAP.
Excellent. 1 for 1. Now, question 2. Which of these is not a typical symptom of severe CAP? A, cough. B, difficulty breathing. C, fever. D, skin rash.
A skin rash isn't usually a symptom of pneumonia, so the answer is D.
Spot on. It's important to be aware of those atypical presentations. Okay, question 3. What's the purpose of a sputum gram stain in suspected severe CAP?
A sputum gram stain helps us assess the quality of the sample for culture.
Okay.
We're looking for white blood cells, a sign of inflammation, and squamous epithelial cells, which can mean contamination. So it's more about checking the sample itself.
Got it. A behind-the-scenes quality check. All right, question 4. The CURB-65 score helps us decide if a patient needs to be hospitalized. Which of these is not a component of that score? A, confusion. B, blood glucose level. C, respiratory rate. D, age.
The CURB-65 score uses confusion, blood urea nitrogen, respiratory rate, blood pressure, and age. So the answer is B, blood glucose level.
You're on a roll. It's easy to get tripped up on those details. Okay, last question. What's the typical duration of antibiotic treatment for severe CAP in adults?
5 days. But as we discussed, flexibility is key. We might extend it based on the patient and any complications.
Perfect. You ace all 5 questions. Now let's continue exploring severe CAP, diving deeper into those antibiotic choices and the WHO's recommendations.
Sounds good to me. It's not just about getting rid of the infection.
Right.
We also want to prevent complications.
Of course.
And really important, minimize that risk of antibiotic resistance.
Absolutely. It's like we're thinking long-term, not just this one battle.
Exactly.
Making sure we have those weapons for the future.
Yeah.
Speaking of which, the guidelines really push de-escalation.
Yes.
Which is basically simplifying treatment to a narrower spectrum antibiotic once we get those culture results back. Why is that so crucial?
Think of de-escalation as a precise attack, targeting that specific pathogen while minimizing collateral damage. Broad-spectrum antibiotics are like using a sledgehammer to crack a nut,
Right.
wiping out good bacteria along with the bad. And that disruption can actually make way for antibiotic-resistant bacteria to take over.
So it's about strategy, not just brute force.
Exactly. And this ties into the WHO's AWARE classification system, which we mentioned earlier.
Right.
It's all about using those access antibiotics first, saving those watch and reserve antibiotics for when they're really needed.
Makes sense, like having a hierarchy of weapons.
Yes.
Starting with the most precise and sustainable and escalating only if we have to. The guidelines also mention step down to oral treatment.
Yes.
Can you remind us what that is and why it's important?
Step down is all about switching patients from IV to oral antibiotics once they're improving.
Okay.
And can handle pills. It's a win-win. The patient gets rid of the IV and maybe goes home sooner, and the healthcare system saves money.
Absolutely, a step towards recovery.
Yeah.
Now let's talk about antibiotic resistance.
The big challenge.
The source mentions it's a potential problem with all those COP pathogens. It's like they're always evolving, trying to outsmart us.
It's a constant arms race. And Streptococcus pneumonia, a major player in CAP, is no exception.
Right.
Luckily, high-level beta-lactam resistance is still pretty rare globally.
Okay.
But the source highlights rising resistance to macrolides like clarithromycin and azithromycin, which we often use for atypical bacteria.
So that's a trend to watch closely.
Definitely.
We need to be vigilant, monitoring those resistance patterns and using antibiotics wisely. The source mentions that CAP caused by low-level pneumococcal penicillin resistance can be treated with higher doses of certain antibiotics. Can you explain that?
Sure. Sometimes with lower levels of penicillin resistance, we can just increase the dose of amoxicillin, ampicillin, or penicillin.
Okay.
It's like giving them a boost to overpower those resistant bugs.
Oh, dosage matters. Sometimes it's not about a different antibiotic, but the right dose.
Exactly.
Before we move on, let's circle back to ruling out TB.
Yes.
The source says we should always consider it, especially in certain situations. What are those red flags and why is ruling out TB so crucial?
TB can be sneaky, mimicking a lower respiratory tract infection.
Right.
We need to be careful in areas where it's common or with high-risk patients, like those with HIV.
Okay.
Look out for a slow onset of symptoms, a cough that doesn't respond to antibiotics, and any history of TB exposure.
Connecting the dots.
Exactly. Ruling out TB is crucial because it needs a completely different treatment, a specific mix of antibiotics for a long time, often months. So we have to change our whole approach if we suspect TB.
So how do we rule it out? The source mentions specific tests.
The gold standard is a rapid molecular test called GenExpert MTB-RIF.
Okay.
It's done on a sputum sample and detects Mycobacterium tuberculosis and rifampicin resistance.
And if that test isn't available?
We can use sputum microscopy. A technician examines a stained sample under a microscope looking for acid-fast bacilli, which are a hallmark of TB.
So, different tools for different situations. Now, let's shift to supportive care. We've talked about antibiotics a lot, but the guidelines also stress oxygen therapy for severe CAP patients. Why is that so important?
Oxygen is essential for the body.
Right.
When the alveoli get filled with fluid, oxygen can't get where it needs to go.
Right.
Oxygen therapy helps restore that flow, making sure the body gets the oxygen it needs to function.
Literally a breath of life. What other supportive care might be needed?
Supportive care is about addressing symptoms and aiding recovery.
Okay.
We might give IV fluids for dehydration, pain relief, fever-reducing medications, and nutritional support.
It's all about helping the body recover.
Exactly, a holistic approach.
Before we wrap up, let's talk about prevention, specifically vaccination.
Vaccines are crucial.
The source highlights that vaccines can prevent many CAP cases. Can you remind us which ones are available and why they're so important?
Vaccines are like training manuals for the immune system. We have vaccines for some major CK players, including pneumococcal infection, Haemophilus influenza type B disease, and influenza.
Right.
They work by showing the body a weakened or inactive version of the pathogen, so it's ready to fight the real deal.
Like a sneak peek at the enemy.
Yes, but remember, no vaccine is 100% effective.
Of course.
And they don't cover all strains. Vaccinated people can still get CAP, but it's less likely and usually less severe.
So it's not a guarantee, but it significantly improves the odds.
Exactly.
We're layering our defenses, using vaccination and good hygiene to minimize the spread. Now let's bring back the WHO's AWARE Antibiotic book.
Yes, a great resource.
Can you explain how it helps us make those smart antibiotic choices?
The AWARE book categorizes antibiotics into access, watch, and reserve.
Right.
Access antibiotics are first-line choices for common infections.
Okay.
They're usually narrow-spectrum, effective, and have a lower risk of resistance. Watch antibiotics need more caution. They might be broader spectrum, have a higher resistance risk, or more side effects. Reserve antibiotics are our last resort, saved for when others fail or for multi-drug-resistant pathogens.
Like a triage system for antibiotics.
Precisely. Using the right tool for the right job. Following AWARE helps slow down resistance and keeps these drugs working.
Absolutely crucial. Let's tie AWARE into severe CAP.
Okay.
Looking at the antibiotic recommendations, tables 27.5 and 27.6, can you tell us which antibiotics fall into each AWARE category and how that affects our decisions?
For adults with severe CAP, ceftriaxone and cefotaxime are the top choices.
Right.
Both are watch antibiotics, so they're broad spectrum and effective, but we have to use them carefully.
Okay. And what about clarithromycin?
Also watch. It's great against those atypical bacteria, but again, use it carefully.
Got it. And amoxicillin clavulanate.
That's an access antibiotic.
Interesting.
Usually a first-line choice, but for severe CAP, it's second line because ceftriaxone and cefotaxime offer broader coverage.
So context matters. Now, for children with severe CAP, the guidelines recommend different antibiotics. Could you explain those and their AWARE classifications?
For kids, the first-line choices are amoxicillin or ampicillin, both access antibiotics, combined with gentamicin, a watch antibiotic.
And if those aren't working?
If there's no response after 48 to 72 hours, we switch to cefotaxime or ceftriaxone, both watch.
A step-up approach.
Yes. And the guidelines mention adding sulfamethoxazole trimethoprim in some cases.
Why is that?
Sulfamethoxazole trimethoprim, an access antibiotic, is recommended for HIV-positive children older than 1 month.
Okay.
They're at higher risk of pneumocystis jirovecii pneumonia.
So we're being proactive, protecting those high-risk kids.
Exactly. Well, this deep dive into severe CAP has been incredibly informative.
It has.
We've covered a lot of ground.
I especially appreciate you highlighting those subtle signs and symptoms, especially in older adults.
It's important not to miss those.
It's all about being thorough. Our listener is now well-equipped to tackle any severe CAP case.
They've got the tools.
They have the knowledge, insights, and resources for the best possible care. I couldn't agree more. And on that note, a huge thank you to you, our expert, for guiding us through this complex world of severe CAP.
My pleasure. Always happy to delve into the intricacies of infectious diseases.
It's been a fascinating journey.
It has.
And to our listeners, thank you for joining us on this deep dive.
Hope you enjoyed it.
I hope you're walking away with a deeper understanding of this infection and some practical knowledge to apply in your practice.
That's the goal.
But before we go, I want to leave you with something to think about.
Oh, good.
We've covered those common culprits behind severe CAP.
Yes.
But what about the rare ones, the unexpected microbes?
Interesting.
Ones causing those head-scratching cases that don't quite fit the usual picture.
Right, the outliers.
Exactly.
Yeah.
I encourage you to stay curious. Keep exploring those less-traveled paths in microbiology. There's always more to learn. Who knows? You might just uncover the next microbial mastermind behind severe CAP.
Always more to discover.
Until next time, stay curious and keep those microscopes focused.